When you're admitted to the hospital, you may be surprised to meet a physician you've never seen before, someone called a hospitalist. Today on Healthy Conversations, we're joined by Dr. Matt Hanserd to explain what a hospitalist is, why your primary care provider isn't always the one managing your hospital stay, and when illnesses like pneumonia, flu, or other respiratory infections require hospital-level care. Understanding how your care team works together can bring confidence and peace of mind during an unexpected hospital stay. Dr. Hansard, thank you for being here with us today. And we're just going to jump right in and let you just kind of explain what is a hospitalist and maybe kind of what drew you into that career as a physician.
Great. So I get asked this just about every day. What is a hospitalist? So I'm an internal medicine board certified physician. So internal medicine doctor is a person that takes care of diabetes, heart problems, lung problems, things like that. I'm based in the hospital, so that's why I'm called a hospitalist. This is something that is pretty new. It didn't exist 25, 30 years ago. But as time has gone on, it's become more and more accepted that there are going to be doctors that are primarily in the hospital to take care of patients that are being admitted. There's a lot of reasons for that, but we'll probably get into that during this talk.
Yeah. Oh, well, yeah. Well, I know you and I've kind of talked about that before. I said, years ago in my career, part of my job was trying to educate the community on what a hospitalist was. Because when it first came about, there were so many people that were like, I want to see my doctor. My doctor's the one who's supposed to see me in the hospital. So it certainly has changed.
Absolutely. And I certainly understand why people say that. Your doctor knows you. They've been seeing you for years. It was a lot for the primary doctors to be able to, they would usually have to come to the hospital very early in the morning, see their patients when they were barely awake, and get all of that done before they went to clinic. And then they were in clinic all day. And then they came back in the afternoons or evenings to discharge their patients. And with more people being admitted to hospitals and growth in population, it just became something that most people couldn't do on a daily basis. There's also a second part to that, which there are a lot of people who come to the hospital who are not associated with a doctor. So a lot of people in America don't have a primary care physician, and those patients have to be admitted to hospitals too. And so part of what created the rise in hospitals is that what we call unattached patients, those patients that don't have a doctor, also needed to be admitted. And so someone needed to be there to take care of them. And then there was one last part, which is what happens when people get really sick during the middle of the day. So you may have an appointment with your regular doctor in their office, but if a patient gets worse during the day and needs a doctor there to be present, it was difficult because the doctor probably had to leave clinic and leave the patients that were waiting for him there and then come back, and that caused a lot of issues in and of itself.
Yeah, that was one of the things that, when I would do the education, one of the things that we'd talk about or explain was, your daughter may, like you said, your doctor may round in the morning and evening. Well, if they put a medication in and by lunch or 1 o'clock, the nurses could maybe think it's not working or you need to make an adjustment, but your doctor's not going to come back till that evening to be able to put that new order in. So we'd kind of try to explain, but the hospitalist is there so they can do that. And of course, when you're talking about the unattached patients, we have fielded those questions for people who see a hospitalist in the hospital and they fall in love with them. And then afterwards they contact us and they're like, where's his office? Where do I go see him at outside the hospital? It's like, no,
So
that's not
that's
how
the
they work.
number one question I get. So number two is what's a hospitalist?
Yeah.
Number one question I get is when are you going to see me after this hospitalization? Where's your
Yeah.
office and what's your number? And that's unfortunate, but I don't have it.
Yeah.
But maybe one day, who knows?
Well, like you said, it is still a new field, but you would think 20 years that, people are still having to kind of understand that. So explain to us kind of what your normal day looks like.
Yeah, so a normal day for me, I usually get to the hospital between 7 and 8. Um, Hospital admissions happen 24/7. So really my day started in the night before because there were patients who were admitted overnight that I'm going to see that morning. So I'm looking over their charts, making sure I've got all the patients who were admitted on my list. So I make sure I don't miss anybody. That's a big part of hospital medicine is list maintenance. Um, and then looking over their charts, looking over the admission process and what they basically came complaining of and what they need done. Looking at all the imaging and things like that. Once I've got a good idea of what's going on with everybody, I start to walk around the hospital. Personally, I go to the ICU first because those are usually the sickest patients, and I run into several other doctors who are seeing patients there. and we're discussing plans. After that, I go out and see patients on our med surg floors, which are 2 East and 3 East at the hospital. And during that time, the ER may be calling me with admission, so there's more people that need to be admitted. So once I'm done with all that, then I start seeing the new patients who are coming in for the day. Um, Somewhere in there, I usually try to catch lunch.
Yeah.
It depends on the job. There's some places where it's really hard to catch lunch,
Yeah.
but usually I'm able to get lunch in Athens, so that's good.
Yeah, and I would imagine, working in any type of medical that your day to day, is so different
Yeah,
every
so
single
our
day.
day to day is different depending on the day of the week,
Yeah.
right? So, and Jordan's over there shaking his head, but it's Mondays for us are absolutely crazy because we also see consultations. So if the surgeon does surgery in the hospital, puts the patient out on the regular floor, we're seeing the patient for their diabetes, high blood pressure, things like that. And so those add on to it, and usually it's a very full hospital on Mondays because there's a lot of people that are waiting over the weekend to go somewhere else. Usually nursing homes or rehabs or things like that. So Mondays are usually our hair is on fire all day Monday. As the week progresses, that hospital volume usually drops a little bit. And then you get to the weekend, and sometimes the weekend's a lot of waiting for people to come back that do specific tests or procedures that aren't necessarily available on the weekend.
Yeah. We've had a lot of Mondays thrown together as one week lately, haven't
Yes,
we?
yes. Yeah, Mondays are rough.
Yeah, and how do you handle coordinating with all the specialists and the nurses? Is that something that you're
Yeah,
responsible
so I
for?
like to say we're communication experts more than we are anything else. And so I have to talk. So one of these days I'm going to bring a clicker in and be like, this number of people communicated with me. But the answer is I probably get thousands of communications a day. So between a cell phone, pages overhead, uh, and discussions with multiple consultants about multiple patients, it's just an influx of information all day. And trying to take all that information and conceptualize it and then come up with a patient plan out of all of that can be difficult. But that's part of why I love the job and part of why you asked me why I chose to be a hospitalist. So I didn't like focusing on one organ system. Like, so when you finish internal medicine, you're going to decide, am I going to be a hospitalist or am I going to be an internist in clinic or am I going to go subspecialized and do a fellowship in cardiology, renal, endocrinology? There's any number of subspecialties. I didn't have one that I loved enough, and I really liked working in the hospital. And it's a really good job for especially for younger physicians, and it's I think it suited me really well. So that's the answer on that.
Well, you certainly get to stay on top of whatever's currently going around because you've got multiple patients all in the hospital with the same thing,
Yes.
the flu, pneumonia, or whatever that is, which I know we'll talk about a little bit more.
And so, Dr. Hanserd, I would like to ask, you touched on it a little bit earlier about why the people's primary care physicians don't, come into the hospital and see them around on them. So, how's that conversation? If that individual does have a primary care physician, how does that communication between yourself as a hospitalist and their primary care physician work? How's that look?
Absolutely. So it depends. If there's something, so the majority of people that come to the hospital come with normal hospitalized problems that we see every day. If the patient has something really special going on with them, or if the patient needs, if the patient wants that reassurance, I always will call the regular doctor and ask them, specifically what they need. I will say that sometimes patients come in and it might be my first time ever seeing them. That's not always the case. There are people that get admitted to the hospital over and over again, but if it's my first time ever seeing somebody and something's really off and like their baseline's not right, sometimes I will call the regular doctor and be like, is this how they are on a normal day? And sometimes the answer is yes, this is actually just their normal. And that's okay. When patients do leave, all the documentation goes out to the regular providers as well as notification that the patient was in the hospital. They'll get a discharge summary, which we do on my group does on patients the day they're discharged. So if they go see like a primary care provider the next day, there's already going to be documentation there for what happened to them in the hospital, and they'll be able to resume care at that point. If there's something specific or high risk, the patient's leaving and I'm starting them on a new medication that needs to be monitored, things like that, sometimes that warrants a phone call too. Hey, this person's coming out. You need to be able to do this.
Well, thank you. That's good to know how that process transitions as they're discharged and, where it goes from there. And then everybody's kind of involved
Yeah.
in that and
And,
knows what's going
some of
on.
it matters because healthcare is built in systems and, like some of the primary care providers that are in the Athens-Limestone system have, kind of similar EMRs and are able to look at hospital records. It gets really dicey when you get outside of that because the EMRs don't talk to each other, and so it certainly makes it harder.
There's more time to get that sent to
Believe it
you
or not,
on.
they still use fax machines to send stuff to offices. I think it's crazy,
A
but
lot,
they
a
do.
lot.
Yeah.
I think healthcare is the only reason fax machines still exist.
Yeah, and beepers.
Yeah,
Yeah,
and you're
beepers.
right,
I have
and
a beeper.
pagers.
I still have a beeper.
You still have a beeper,
I still
Jordan?
Yeah.
Okay.
Yeah, I can see that. So in talking about, discharging, like when we're talking about the physicians and stuff, so a lot of times in kind of the discharging of patients, do you typically kind of go ahead and set up those follow-ups with
Yeah,
their
so a lot of
physicians
times
before
we're
they leave?
calling and setting that up. So let me go back to that unattached group of patients. So these are people that don't have a doctor at all outside the hospital. We have a call list at the hospital. So if you're going home and you don't have a doctor will be assigned for you and we'll get you an appointment within a few weeks to be seen. And most of those are physicians that are associated with the hospital. If, if you need a quick follow-up, a lot of times we'll call and make that appointment. Or if you don't need a quick follow-up, so some people, it's like, yeah, you were in for this, but you actually don't need to be seen in a few days. Sometimes people just go back for the regular appointments.
Okay. Well, let's just transition over to kind of what all we've been seeing. Pneumonia, flu,
So much
respiratory.
flu. Everyone in the office now, we had someone leave halfway through the day today. My husband's home with the flu. Everyone's
Yeah, and
sick.
it really does affect everybody. I've had 2 daughters with the flu this year, I think, already. It's probably
Yeah.
more than that. I think multiple of us had it. It's just part of nature, right? So flu season comes every year. The flu in a normal year causes people to be admitted to the hospital, especially elderly people, and little babies and young children. As we have, I think every year we have this discussion: is this flu year worse than the other flu year? And I do, because I'm from North Alabama and from Athens. I'd like tell parables about severe weather because everybody in North Alabama understands severe weather. So, is this year a bad year? Well, yeah, every year is a bad year. There's going to be some storms and some people are going to be affected every year. Is everybody going to be affected? Is it 2011? It was 2011, right? That
Yeah,
was the really bad
tornadoes.
year.
Yep.
Is it 2011? Well, that only comes every once in a while, right? So people need to understand that that's the case. Just because it's not a bad flu year doesn't mean that you personally aren't going to have a terrible case of flu, right? Just because it's not a bad weather year doesn't mean that your property might not be destroyed. And yours was the only one,
Yeah.
right? Does that make
Yeah,
sense?
it does.
Yeah.
And but it's a natural process, right? So flu is not going to go away. I don't think it's ever going to be cured, right? It's just flu actually lives. You may not know this. Flu actually lives in birds and it lives in pigs. It lives in things that aren't humans. So even if we were to cure all the flu that was going on with humans, we still have animal reservoirs, and so flu comes around every year. And it actually circulates on the other side of the earth in the other parts of the year. So it's circulating all the time, right? So if you're on the southern hemisphere, their flu season is different than our flu season. So I think that's all I want
Yeah.
to say about
Yeah.
that. Yeah.
Yeah.
Yeah, and you were talking about those higher risk groups and hospitalization. At what point do people usually get admitted for
Yeah.
those
So
conditions?
there's kind of like subsets of flu patients that get admitted. You have elderly patients who just get so weak they can't get out of bed. Okay, they don't have pneumonia, they don't have anything else. They get dehydrated because they can't keep fluids down. Their body is so revved up from having the flu, and those patients get admitted. A lot of times, all I'm going to do is give them fluids, and they're better in a few days, and they either go home or go to rehab. There's another subset of patients, which are people that get flu pneumonia. So the virus actually causes a pneumonia in those patients. They require oxygen. So they're sitting at home and their oxygen levels are getting low, and that's making them very sick. Those patients have to be admitted and we have to give them supplemental oxygen for several days, a lot of times to get them better. There's a portion of that group that gets really, really sick, has to go to the ICU. They develop something that we probably remember from the pandemic called ARDS or ARDS. And those are oftentimes the patients that end up passing away from flu. So the third group are babies and especially children less than 1 year of age. And I'm not an expert in that, just to let you know. I've had 4 kids, which makes me think I know something, but I'm not a pediatrician, so I usually defer to them on most of that.
All right, so in touching on like the respiratory illnesses and that nature, so just explain to us what the role of vaccines play in preventing.
Yeah, absolutely. So, we'll specifically talk about flu. We can talk about some of the other viruses, in a second, but flu vaccine is something people are really comfortable with because it's been around for a long time. Um, it I think the best way to describe flu vaccine is to talk about what it does and what it doesn't do, because I think a lot of people are under the impression that, well, I got vaccine, I'm not going to get the flu. So you can get the vaccine and you can still get the flu. It decreases the chances that you're going to end up in the hospital. It decreases the chances that you're going to die from the flu, and those two things are incredibly important. Um, flu, as I talked about, is a natural phenomenon. People are going to get it every year. I had 2 kids get it. Did they have flu vaccines? Yes. Did they still get it? Yes. How long were they sick with the flu? This is anecdote. So anecdote means this is my own personal experience. It's not the experience of thousands and thousands of people. But my own personal experience is I had 2 kids that got the flu and they were better in 48 hours. A normal flu case is 5 to 7 days, and people are usually terribly sick with it. And so I think that probably decreased their length of symptoms. That's just me personally. But you can still get the flu. The hope is you're not going to get as sick with it, and you're not going to end up in the hospital, because this time of year, the whole hospital fills up. It's a combination of flu and a lot of other things. It's not all flu. But these are the sorts of things we can do to decrease risk.
And so touching on that as well, so when early treatment, so early treatment when you do get the flu, or if you do get the
Yeah.
flu, how important is early treatment to postpone a hospital
It is,
hospitalization? So
it's important in that it's available. It's not perfect either, and I'm gonna talk about this in medicine. There's no, like, cure-all, everything's perfect, okay? There are very few things that are like that. I will say that if you start to have fevers, chills, muscle aches, and cough this time of year, and you go get tested for the flu, whether you go to an urgent care or you go to a pharmacy and get your own test, and you test flu positive for A or B, there are some medicines that are available that will decrease the length of symptoms. Okay, this is whether you're vaccinated or not. You can take these medicines and they will knock usually a few days off. One of them is called Tamiflu. It's been around for years and years and years. It has some side effects. It has GI side effects to it. And it can cause some people to be a little bit more confused when they have the flu. It's, to be honest with you, not my favorite drug, but it's one that was available forever. There's a new one called Xofluza, and it's very well tolerated. People take it, and it usually takes some days off the flu as well. The other thing about Xofluza specifically is if one person in the house has it and they've been around everybody else, especially if you have high risk people in the house, they can actually take it as a prophylaxis before they get the flu. Like, this person's got it. We've all been around each other in a small room. I can actually take this medication. Downside to Xofluza, it's not cheap. About $100 out of pocket per dose. So there you go.
Yeah. I've heard people that are doing that, like, when one gets sick and they're all fixing to go on a vacation,
right.
or it's, like, right before Thanksgiving or right before Christmas, and so they kinda get everybody in the household that to try to.
It might be worth it in that case.
Right, right.
And yeah, so I think both of the medicines have their place, but again, not perfect, right?
Right.
You're gonna hear that a lot from me.
Yeah.
I understand.
Well, so, um, back to just patients in the hospital. So, how do you monitor that progress daily? I do know that most of you, work, like, 7 days in a row, so you're probably seeing the same patients a
Yeah,
lot?
so that's a good point. So I have a switch partner, and he and I make a schedule, and we at Athens, we don't quite do sevens, but it's something similar to that. Monitoring progress is really important because when you get like a data point, so the first time I walk in and see a patient with my eyes is a data point. If that patient does not look well enough to go home, they're going to stay in the hospital a few days, and I'm going to see them get better, or I'm going to see them get worse, or I'm going to see them stay the same. And that's going to maybe change what I do on the day-to-day basis. I get on my first day on the day that I'm usually running around with my hair on fire. I also get sign out from my partner from the day before. So he tells me what's going on with who the patients are, what's going on with them, what the plan is. And because people tend to get admitted to the hospital with the same sorts of things, the vast majority of it's already ingrained in my mind. I don't have to, this patient's here with COPD. I already know what's involved with that. So, it's a process by which you follow the patient day to day and make decisions.
So what's the average census of patients that you take care of on
Yeah,
a daily shift?
So we have nurse practitioners
Mhm.
too. I believe last year my average number of patients I was seeing a day was 22.
Okay.
But that's there's also a nurse practitioner. They see a little bit, maybe the lower acuity patients. So they see a lot of the consult patients and things like that. We're seeing more of the ICU patients and the patients on the med surg floors. But it's a growing community. So my number has gone up. I've been here, I think, 11 years now. My number has gone up every year as far as what I've seen. And it's very dense work. I would just say that.
Well, and we are fixing to add more beds.
That's right.
Just as the growth continues.
Yes.
So, how many hospitalists do we have and how many nurse
Oh my
practitioners
goodness. So traditionally we've had 4 full-time hospitalists. We just hired on someone else. So we're going to
Okay.
have 5, and that person's going to help at night. And then nurse practitioners, there's 4 full-time during the day and a couple and usually a couple full-time at night. So the list grows and contracts at times, and then there's some people that just work part-time and don't work full-time with us. It's a fun group to work with. It's been probably the greatest joy of my life was coming here, starting the group from scratch, from like day one, and then growing the group over several years, and then starting to add new things to Athens, right? So when I got here, there were subspecialists that weren't available yet. We would have to transfer out for those sorts of things. The one thing I can make kind of clear in this is we can take care of a lot more than we used to be able to. I think a lot of people get stuck in thinking about what something was like 10, 15 years ago. But like, come check us out now if you haven't. All the hospitals in North Alabama are full, so it doesn't really matter which one you go to. If you need subspecialist care, if you need something specific done that we don't do, we work out processes by which we can get you to other hospitals in the system where they do that. It's very common for us to transfer patients for a procedure at Huntsville and then them transfer them right back, as opposed to they have to sit in Huntsville for 2 or 3 days. They're a 45-minute drive. The patients from West Limestone, they're an hour drive away. Families having a hard time getting over there, all those sorts of things. We can handle most of that stuff in Athens now, and I would really encourage people to come check us out.
Well, and that is definitely one of the benefits within the system because, like you said, the system does really believe in trying to get the patients back to their home hospital, I guess you'd say, for those benefits, being able to see your family and the travel and the parking and just all of those
Yeah, I mean,
kind of things.
I'm from here. I grew up here. I don't like to have to like go into parking decks to park in hospitals and things like that. I like to be able to. I mean, it's not that I'm nervous or can't do it. It's that I would rather do it in the hometown style.
Yeah, yeah. We're growing, but we do still like our
That's right.
culture, our small town culture and size.
Absolutely.
So, well, kind of one last question regarding the hospitalist and the hospital stay, kind of for patients and families, how can they be proactive in staying informed or a part of the care from your standpoint as a hospitalist?
Yeah. Like, if I had to give people recommendations about some things to do before coming to the hospital in case a hospitalization happens, the first is to have a list of the things that are wrong with you, like your diagnoses, the medicines you take and how you take them. So the medicine, the dose, and how often it's given a day. The list of the surgeries you've had before. If you have those, if you're able to give me that when you walk in, it makes everything so much easier than me having to quiz you and you tell me all of those things individually when you come to the hospital.
And trying to remember them.
And trying to remember them. Because I've already, just during this podcast, I've already forgotten 30 things I probably meant to say, but I didn't say, right? So if I quiz you right now, what medicines do you take and exactly how do you take them, you're probably going to miss one, right? And so if you have those lists, it makes things easier. And it's probably less than 10% of patients that come with those lists, but they're really important. The other thing is if you're an elderly patient or a patient and you have an advanced directive, you want certain things done at the hospital, but other things not done at the hospital, bring a copy of that with you to the hospital. let people know when you come in the door that that's the case. Because there's some people who don't want really aggressive ICU level care. There's certain people who absolutely want that. I want to know when you come in what you want, what you don't want, so I can help guide what the care is to you and what your personal preferences are. So that's important.
Yeah, we have that list for my mom, with all the medicines and all the surgeries and all that to make it easy, but I will have to admit I don't have one on myself.
Yeah, that's right.
So,
You don't, and most people don't. But you know
yeah,
what? Everybody's got a cell phone now.
yeah.
Put that if you got an Apple phone, put it in notes, or
Mhm.
I don't know what the Droid people do.
Well, I took a picture of hers and have it as
Nobody
a
knows what
PDF on
they
my
do.
phone,
But
yeah.
whatever the Droid people do, they can put it in their notes too.
If all else fails, bring them with you.
Yeah.
My grandfather used to bring a bag with him when he came.
Well, and that works
Yeah.
too. And that works too. And then if we get that bag, we can look at it and be like, you haven't filled this in 5 years.
Yeah.
So, that's the other thing. If you're not taking something anymore, mark it
it
off
out.
the list. Mark it off the list. Really one of the most complicated things in hospital medicine is getting the medicine list right. And it requires what we'll call the pharmacies. Like, we'll get a list and then we'll call a pharmacy and they'll be like, they haven't filled that in several years. And it's like, oh, well, that's okay. That shouldn't be on the list, but it's really complicated. Let me just put it that way. But if you as a patient take ownership in making sure the list is right, it helps us tremendously.
Well, and some people can take something for so long they forget what it's even for. I know recently it was one of those of, well, do you take a heart medicine? No. Well, it's listed right
Well,
there.
yeah,
And it's
they
like,
don't.
yeah, but they kind of forgot that's even what that's for.
Yeah, and I kind of understand that too. I mean, I don't think any of that's that the patient maybe doesn't understand. I think sometimes it's just so complicated.
Yeah.
And, the medicines are not easy to say. Every medicine has 2 names, which some medicines have 3 or 4 names for the same medicine
Yeah.
at the same dose. I mean, it's gotten a little ridiculous sometimes at how complex it all is and how we kind of I think how the medical system expects patients to be able to understand and take care of the majority of this stuff. It's really hard.
Yeah. Well, I mean, I certainly appreciate the hospitalist role. And again, 20 years ago when I kind of got introduced to it, it was so new at the time. And I learned so much by trying to educate others about it. And it has just grown. You look at healthcare and you think so many things, cardiologists, pediatricians have been around for so long, but there are still so many things that we're changing and adding and advancing.
It changes all the time. And I like here at year 11 for me in Athens, the job is different than it was even in year 10 or 9. New things come down the pike. I think probably in a year or two, we're probably going to be looking at a new electronic medical record in Athens I've been through that process of putting one in a hospital. It can be very painful to the people that work there, but it's good for the community, right? So we're going to have open access to everything that's happening in the electronic medical record at Huntsville. And so if you've been in Huntsville Hospital, we're going to be able to see that, or in their clinics, we're going to be able to see that right away. It doesn't require us working out of 2 systems, which is really hard to do.
Yeah. And same thing for somebody who has to transfer
That's
for
right.
some reason
That's
from
right.
us to them. It just
Yeah.
makes it seamless
Yeah, I
and
think
quick.
that's going to be a big step towards making this a hospital system across North Alabama.
Yeah. Well, that's
Closes that loop of communication too. Everybody's
Absolutely.
involved.
absolutely everybody's
Absolutely.
involved. Well, thank you so much for talking to us about hospitalist program. But before we leave, I know you and
Oh,
Jordan
yeah.
kind of have a unique kind of
Yeah,
how
I
we
like
first
rolled
met.
I rolled my
So,
eyes all the way in the back of my head when I saw Jordan. I can't believe we're going to talk
so you
about
might as well
this.
just spit it out.
So, in typical middle-aged fashion, I had a couple of young kids. I was overweight, was tired all the time, and I was like, you know what? I'm going to start working out, and I'm going to get a personal trainer. And at the time, I guess technically he's still a personal trainer, but at the time, Jordan was at the Athens Wellness Center, and he was my personal trainer when we started. Well, I wanted to go in.
100%.
Guns
Go ahead.
a-blazing.
Go ahead. You
Guns
tell
a-blazing.
the story. You
Dr.
tell the
Hanserd,
story.
he wanted to come in guns a-blazing in typical fashion. What we do with somebody starting, we give you 2 base packages. You can do 30 minutes, you can go an hour. And he comes in and he says, Doc, do you want to do, an hour session or you want to do 30 minutes? He said, I want to do an hour. I was like, how long's it been since you worked out? He's, it's been a while. And I was like, we might want to start with 30 minutes. He said, no, we're going to do an hour. And I was like, okay, we'll do an hour. About 30 minutes or so into the hour, he stops me. He says, I got to leave. I got to go home. I got to go home. I can't. I'm leaving. So he leaves, and I get a call from him probably an hour after that. And he said, I had to stop on the side of the road on my way home. I just want you to know. I had to stop on the side of the road on the way home, and I didn't make it back to my house to, throw up. And so the next time I see you will be for 30 minutes, and we'll continue until I tell you differently. I said, yes, sir. That's what we will do. And that's how we first met.
So the moral of the story is that if somebody does something all the time and they recommend something to you, and this goes for the hospital too.
Yes,
Like if I
yes.
recommend something
wanna
to
take that
you,
advice.
you might want to like take that into account.
So, in other words, there are people smarter than you in certain areas, and you should
In
listen.
almost every other area in life, and there are a lot of hospitalists that are smarter than me too. But I will say, like, like listen to them. Listen to your tax professional
That's
about
right.
taxes.
That's right.
It's amazing how many people ask me about taxes, and I'm like, this is a bad idea.
Yeah, listen to your realtor,
Yeah.
listen to your tax professional,
Yeah.
listen to your lawn service guy.
That's
Yeah,
right.
absolutely. Okay. Well, thank you so much for joining us. It's been very educational, and we appreciate your time.
Thank you.
Thank you, Dr. Hanserd, for helping us better understand the important role hospitalists play and when respiratory illnesses require a higher level of care. Knowing what to expect during a hospital stay can make a difficult situation feel more manageable. Healthy communities start with healthy conversations. Thanks for being part of ours.